Group Methodology Lecture Series. And this month we have a return visit by Dr. Jennie Haw, who is going to be speaking on retaining the patient perspective in the design and conduct of research protocols. Jennie Haw is a scientist in donation policy and studies at Canadian Blood Services, and she is a qualitative methodologist with specialization in the sociology of health and critical donation studies. She draws on social theories to examine donation within the context of broader health and social systems. A key area of focus in her research program is understanding blood donation from the perspectives of historically excluded and underrepresented groups, and identifying social and structural barriers and enablers to donation. So, Jennie, I will give you the floor, and you may start whenever you are ready.
Thanks, Jason. Are you able to see my slides?
Yes.
Okay.
You're on presenter view if you want to switch your...
Yeah. Okay, here we go. How does that look? Good?
Perfect.
Okay. So thank you very much for the invitation to present. I'm going to talk today about community-based participatory research or patient-engaged research, really an approach to research that aims to lead with community and patient perspectives. And this is an approach that I've applied over the past 5 years as a social scientist here at Canadian Blood Services. And I consider myself to still be learning about this approach. So I'll share some of my experience applying this approach to research, and also just share with you what is out there in the literature as well. So here are the objectives. In today's talk, I'll introduce CBPR and patient-engaged research and outline some of the underlying principles that guide this approach. I also want to spend some time providing some practical or concrete examples of how to apply these principles in health research studies, both through my own experience as well as some guidance offered by other researchers in this space who apply a CBPR approach. And then lastly, I'll consider some challenges and tensions, and then I don't have it here in the objectives, but also will include a slide about evaluating CBPR approaches in research. So when I present on community-based participatory research, I like to start by sharing the wide range of names that CBPR is known by, and you may recognize many of these names. So in addition to CBPR, others refer to it as action research, participatory research, decolonizing methodologies. What's not included here, I've also seen co-design. Then when we turn to patient-engaged research, again, we have more terms here: patient-engaged research, patient and public involvement, patient-oriented research. And I bring these terms together, and I will kind of use them interchangeably, because patient-engaged research really has its roots in participatory research or action research. And I want to flag that there are some important or nuanced differences amongst these different applications. But for the purposes of this presentation, I'm going to talk about them kind of as a unified approach to research that really aims to change the way research has traditionally been done. And so in the social sciences, CBPR emerged as early as the 1940s. Kurt Lewin wrote about action research. And the CBPR emerged out of a context where researchers were going into communities. Participants and community members were viewed as passive objects of study. Research was considered to take more of an extractive approach, where the researcher would go in. The study participants would provide the data that the researcher needed, and then the communities didn't necessarily benefit. And in some cases, they were harmed by the research. So CBPR was an approach that was developed to respond to this and to challenge traditional ways of doing research, and aims to share power and decision-making with communities and participants, and to the extent possible, involve communities and participants as active members throughout the research process. So you might have heard doing research with participants as opposed to on participants. Um, and it's a methodology. Oh, and one other point, it's an approach to research. It's not a methodology or method. And what that means, that distinction is important because it means that a community-based approach or patient-engaged approach can be applied to different methodologies and methods. So it can be applied to qualitative studies, quantitative studies, clinical trials. So as a sociologist, I like to think about, how and under what conditions did certain approaches to research or methodologies emerge. And so this is just a very brief overview of CBPR in health research. So it goes back to the 1980s and 90s. A lot of public health researchers started questioning the focus on individual level factors. They were noticing that there's a lot of research being done, but there's a growing gap in health status amongst people in different communities, despite all this research being done. And they started calling for more attention to what they saw as the gap between research and application. So by 1998, a review was published by Israel and colleagues. And this is really quite a seminal piece of work in CBPR and health research. And what they did was they did a review of all the studies that took a CBPR approach in health research to outline what are the principles underlying CBPR. At the same time, funding was provided to better understand this gap between research and public health disparities. So in 1984, in the US, Congress provided funding to the CDC to fund prevention research centers. And it was aimed to increase collaboration between researchers with policymakers and citizen groups. And what this resulted in was a nationwide network. In the mid-1990s, the CDC commissioned the Institute of Medicine, now called the National Academy of Medicine, to review the prevention research centers. And the chair of that review at the time recommended that organizations all adopt a community-based participatory approach. So from the 2000s onward, there was funding dedicated to CBPR projects in Canada, in the US, in the UK, and other countries. In Canada, CIHR established the strategy for patient-oriented research, and the framework for this was published in 2015. And on the map, you can see the SPORE centers in provinces and territories across Canada. So what were some of the principles that Barbara, Israel, and colleagues identified in their review? So they identified 8 different principles. First, recognizing the community as a unit of identity, and this involves acknowledging the unique characteristics, values, and priorities of community members, and then involving community members in all stages of the research project. Building on the strengths and resources within the community. So really identifying and valuing a community's existing knowledge, experiences, skills, and resources, and involving them as much as possible as equal partners in research. Third, co-learning among community and academic research partners. This really emphasizes the importance of a collaborative and reciprocal learning approach between community members and researchers throughout the research process. And I think it's really important to me, what's really important here is also about recognizing the expertise that community members bring to the research project, to the question being studied, and not prioritizing expertise or knowledge of researchers over community members. Next, balancing research and action for the mutual benefits of all partners. So this stresses the need to balance rigorous research with practical interventions and policies that benefit the community. So it's not just the researcher who should benefit from the research or even be prioritized in terms of the benefits of the research, but it really is about ensuring that the needs and priorities of the community and the communities impacted are being met, and that they are receiving benefits of the project as well. Emphasizing the relevance of community-defined problems. Again, this comes back to really recognizing the expertise that communities bring to the project, that they are the experts on understanding the needs of their community, what works in their community, what are challenges in their community. Employing or involving a cyclical and iterative process. This is about developing and sustaining community research partnerships. So this principle really recognizes that effective partnerships require ongoing engagement and evaluation, that it takes time, that it requires regular meetings, open dialogue, shared decision-making. Disseminating findings and knowledge gained to all partners. So again, this is about highlighting the importance of ensuring that communities involved, community members, communities impacted, also are recipients of the research findings, that research findings are shared in a way that's accessible and meaningful to them. And then lastly, long-term commitment from all partners. This principle is really about underscoring the importance of sustained engagement, collaboration, and investment from all the stakeholders involved in the research partnership. And so really about recognizing that projects that take a CBPR approach are not necessarily projects that should be viewed as kind of one and done. You've got a research question and you want to answer that research question and then the relationship ends, but really about viewing the relationship with community partners as a longer term relationship where you're building over time and over multiple projects, the relationship that you have with communities involved. So why apply a CBPR approach or a patient-engaged approach? So various reviews have been conducted on studies that have taken this approach in health research, and there are various benefits that researchers have noted from applying this approach. So improved study enrollment, lower attrition rates, increased relevance of the research, in particular to the communities affected, increased accessibility of study materials to the study participants, improved trial design, increased meaningfulness and understandability of disseminated findings, and increased validity of the study results. So you can see that there are benefits to applying this approach to health research. I also looked at a couple of systematic reviews of CBPR approaches applied in clinical trials. I won't go into details about these two reviews here. The first one was conducted in 2012 over a period of 2000, looked at published studies in 2003 to 2010. And then McFarlane wanted to see what had been done from 2010 to 2020. So you can see that over time, there's been a significant increase in the number of clinical trials that have taken on a community-based participatory approach. In both reviews, they found that taking a CBPR approach seemed to be advantageous when recruiting underrepresented racialized groups to clinical trials. And both also noted that there wasn't a lot of detail in terms of how were community members engaged in these trials. And McFarlane goes on to say that they recommend that greater detail on community engagement be provided by trialists when publishing their results. Research has also been done to see, so despite the benefits, studies show that there is still some hesitation by researchers to take up this approach. And a couple studies have found that there are two kind of areas or themes for why this hesitation. One has to do with uncertainty about how to engage patients. So researchers have said that, they're not quite sure how to engage patients in the research that they do. And if we just refer back to the slide that I just shared, and the reviews that were done that show that a lot of these papers don't provide a lot of detail in how they engaged patients in their studies. This isn't too surprising. And then the second theme, the challenge of needing a culture shift to support CBPR or patient-engaged research collaborations. So this is about redistribution of power. So in the traditional model of research, the researcher kind of holds all the power, makes all the decisions. With CBPR, it's about sharing that power with community members, restructuring traditional research paradigms to support shared decision-making throughout the study, and mutual understanding and a shared vision for the research collaboration. So again, this is about researchers and community members, patient groups, developing a shared understanding, shared goals for what they want to see from their research collaboration. And that takes time, can't be rushed, and also requires relationship building and trust building. So how do we put CBPR, our patient-engaged research principles, into practice? There isn't a simple formula, there isn't a single framework, and this is something that really needs to be adapted to the specific project and the research study, the research question being tackled, and the communities involved. So there's no single way that communities or patients or publics can be involved. And if we consider the principles, we want communities to be involved throughout the research process as much as possible. It's also important to recognize and attend to the needs and priorities of communities involved and the resources that they have. So he and colleagues created this schematic to say, rather than saying that some projects apply a CBPR approach in the right way, in quotes, in the right way versus the wrong way, because in some cases, communities may not be involved extensively in every step of the research project. They say, let's think of it as a continuum. It's more productive to think about community engagement, patient engagement in research as falling somewhere along a continuum where on the far right side, you have projects that are community driven, community led, and there are some projects where the community will identify a need and then seek out researchers to conduct the study with them. Straight through to the other end of the spectrum where the community, their role might be to be informed of the project and perhaps provide some input or be a key audience once the research is done. So this is something to keep in mind as you think about how might communities and patient groups be engaged in the projects that you might be thinking of developing in the process of developing. So from a traditional, if we think about applying a CBPR approach and moving from a traditional approach to a community-based approach, there are various elements of the research project or the research study to think about. And this is kind of a list of various aspects of the study that Collins and colleagues have developed. If we think of a traditional approach to research, the researcher-participant relationship is largely limited. The participant is really the object of study, the person who provides the data that the researcher will then analyze and produce some results and findings and publish. And in the more conventional or traditional form of research, the researcher is the one to kind of be the decision maker, hold the power in terms of how what research question is under study, obtaining funding, oversight, determining the research design and intervention, collecting the data analysis. Publishing is primarily focused on publishing in peer-reviewed journals, presentations primarily to an academic audience, and then sustainability may or may not be a consideration. In the case of a community-based approach, the researcher and participant relationship really is at the heart of a community-based approach. The relationship is important, it is prioritized, and it's a relationship that is developed over time. Community members as well can have official status on community advisory boards and potentially be co-investigators on the research team. So the relationship between the researcher and participant is much more than one in which the participant just provides the data that the researcher needs. The research idea or question is one that is co-developed. It's identified in collaboration with impacted communities. And the research questions ideally are driven by the community's expressed needs and or prioritize the needs of the community. Funding, communities and researchers can work together to secure research funding. There may also be opportunities to look for funding that is geared towards fostering academic community partnerships in terms of supporting community capacity building. So there may be funding opportunities that are geared towards supporting a community-based approach. Oversight, in addition to, oversight that's provided through the Research Ethics Board, with community-based projects, it's important to consider, is there a role for community oversight? Community oversight can protect the values, ethics, and interests of communities. This can be done through community members being on a steering committee. There might be a specific oversight committee that's formed that community members can be invited to participate on to provide oversight of the project. The research design and intervention design, again, are can be ideally co-designed with community and or with community input. Community members are the ones to provide really invaluable insight into what kinds of interventions may or may not work for their community. They can provide input on interventions and research design by being part of community advisory boards again, or they can be a member of the research team. Data collection and analysis. Community members, again, can be involved in helping with data collection. They can be trained to participate in data collection. They can be involved in providing guidance and input on recruitment materials. They can provide input on interview guides. In terms of analysis, they can be involved in some studies, they have offered training to community members in aspects of data analysis. So community partners also participate in data analysis. In other projects, they provide input on analysis that the research team has completed, and they provide input on any additional questions that they might have regarding the analysis and or what they find significant about the analysis. Publication and dissemination. Communities can be involved in publication. They can be co-authors on peer-reviewed publications. It's also important to consider community input on outputs, written outputs that go beyond publishing in peer-reviewed journals. This can be resources that would be useful to communities. In terms of dissemination, community members can really guide where and how the results of the study are shared, identifying opportunities to share the results with community members. ensuring that the results are written up in a language that's understandable and culturally appropriate to communities and community members impacted. And lastly, sustainability. So this is something that is really prioritized in community-based research. It's about looking for funding that could extend beyond a single project, funding that might enable ongoing collaboration with the researcher and community partners involved. It could even be a commitment by the researcher with the community partners involved to continue their collaboration beyond a single study. It can also involve ensuring that the data and findings are available to the community for future funding requests, regardless of whether the researcher is involved in the subsequent study or not. So it really is about ensuring that the community has the resources available so that they can continue on this work as well, should they desire to do that. So I'll turn now to a project that I've worked on, just to give you a little bit more kind of concrete examples of how I've engaged community partners in one of my projects, and how we worked with community members throughout the research study. So this is a study, I don't have the title up here, but it was called Sickle Cell Disease and the Need for Blood. It's a study that was initially it was initiated by the Sickle Cell Disease Association of Canada. They had been working for quite some time to increase awareness of the need for blood and blood donation within African, Caribbean, and Black communities to help support the needs of people living with sickle cell disease. And they had, hosted various drives and recruitment campaigns, particularly with young adults, and they were finding that they weren't getting a lot of uptake. So they approached Canadian Blood Services to see if CBS could collaborate with them on a project to better understand why it is that young adults aren't donating. What are some of the barriers to donation? And so that's how I got in touch with them initially, and that was back in 2020 when we started our first study together, and we have since gone on to collaborate on additional subsequent studies. But for this first project together, so SCDAC and a second sickle cell organization, Sickle Cell Foundation of Alberta, were both invited to be co-investigators on the project. So they were co-investigators on the project, and together we identified study objectives. So again, based on what they identified as a need and what they were hoping to accomplish through the study objectives and research questions were to identify barriers and enablers to donation for African, Caribbean, and Black young adults. They had created some recruitment and educational materials, as did CBS, and they wanted to know, are these materials actually working? What do people think of these materials? So we assessed these materials, and then our third objective was to make some recommendations to CBS. So together we worked on a grant application. So for the SHARP funding application, I wrote the initial grant application. Writing a grant requires specific language. There's specific grant writing languages, I'm sure many of you know. And so that was a skill and experience that I brought to the research team. And so I drafted the grant application. I shared it with my co-investigators, and they provided really good input on the grant application. They highlighted things that they thought were really important, that they really wanted us to emphasize in the grant. And so we did that. We submitted the grant and we applied to the Partnership Engage grant, which again is a specific grant that's dedicated to encouraging partnerships between community organizations and academic institutions. So that's a funding grant that we thought would be really aligned with what we were trying to do. And then once we were successful in getting that grant, we formed a community advisory group. And a community advisory group, I'd mentioned it a few times in my previous slide, is a really effective way that a lot of different studies that take a CBR approach have applied in engaging community members in the work that they do. Some call it a community advisory committee, community advisory group. Some projects have referred to it as peer researchers, which is a slightly different role. But I just wanted to spend a couple slides talking about a community advisory committee or group because it can serve a really important function on a research project and how to engage community partners. So several questions to consider. What is the purpose of a community advisory committee? Do you want them to provide guidance? Do you want them to steer the project? Are they there primarily for oversight? What role do you want them to play in the project? Are there any specific tasks that you want this community advisory group to be able to do? If so, you'll want to think about who will have the skills, experience, and the resources to be able to do the things that you are asking them to do. And then who and how will you invite to be on the committee? So for our project, we wanted the community advisory group to provide input on our research tools, including our study instruments, the interview guide, the recruitment poster. Would it attract the people we were trying to attract? Would it be understandable to the people we wanted to recruit? And for the interview guide, were the questions clear? Would they be understandable to the people we would be interviewing? Was there anything in the interview guide that we were missing that we should add to the questions we would ask in our interviews? We also wanted people, we wanted members of our community advisory group to help us with recruitment. So we wanted people who identify as African, Caribbean, or Black with lived experience of sickle cell disease and or interest in blood donation. And we wanted to get as wide a representation from from provinces across the country as possible. We wanted this because we know that ACB communities are highly diverse, and we wanted to hear from as broad a cross-section of folks as possible. So we invited people to join our community advisory group by we wrote up a summary of the project. So what we aimed to do in the study and why, and what we anticipated as the impact or outputs from the study. And then what we were asking members of the community advisory committee to do for us or with us on this project. So we wrote up a summary, and then we shared that through SCDAC as well as Sickle Cell Foundation of Alberta. So through the two community partners that were on the research team, they shared it through their networks. And in total, we had 6 community advisory group members from 5 provinces across the country. And we also paid them an honorarium and provided an opportunity to co-author on the outputs of the project as well. So when we initially met as a group, we also developed terms of reference for the community advisory group so that everyone was clear on what it was that we were asking them to do, how many hours we anticipated they would be involved in the project, and when throughout the project. So we developed kind of a broad timeline for the entire project when we anticipated we would want their input and how and where along the timeline we would be reaching out to them to provide input for us. So the community advisory group, again, provided guidance on the recruitment poster and the interview guide. And here's an example of the recruitment poster that we finalized with them. They also were really helpful in recruiting participants to our study. We anticipated that we'd have some challenges recruiting in the public. And so They were helpful in sharing the recruitment poster amongst their networks. Data collection was done by their research team, as was analysis. And then we shared this with the community advisory group, and they provided input on our results. They asked questions. There was discussion about additional analytic areas or analytic questions that we went back to and looked at in greater depth. And then they also provided input on the recommendations from our data and our findings as well. And then knowledge translation and dissemination. This is where the community advisory group and really the community partners on the research team, so the co-investigators on the research team, really took a lead in knowledge translation and dissemination. So in addition to publishing in a peer-reviewed journal, we also created a recruitment guide, as you can see there in the poster with the blood donor recruitment guide. And that was to provide guidance to community members and community groups who are recruiting young adults to become blood donors. And this was something that was considered to be really important from the community's perspective. Again, in addition to presenting results in academic conferences, we held a knowledge forum, and this was a joint effort between CBS and SEDAC. And it was an opportunity for us to share our results with a community audience, so we were able to share with them what we learned through our study. This is just a resource I wanted to share with you all. This is an edited volume written by Barbara Israel and colleagues. I found this to be really helpful, just in providing a lot of concrete examples on how to engage patients and publics in research. They have a chapter here where they go through strategies and techniques for effective group process. So there's a lot about, form a community advisory group, form a committee, work with the committee to do X, Y, Z. But I found what this book offers, and a chapter in this book specifically, is how to get that committee to work together as a group, the work that's needed to build relationships so that everyone has a voice in that group, so you can ensure that power is distributed equitably, that people aren't there just kind of tokenistically and not able to speak up. So I just wanted to share this resource in this talk as well. Okay, so I want to turn now to involving patients in clinical trials. So to provide a little bit, because I don't have any firsthand experience in clinical trials, I wanted to see what was out there in terms of some resources specific to clinical trials. So this is a paper published by Evans and colleagues. They're out of Wales, they're a team out of Wales, and they too recognize that a lot of the work that had been published to date had really focused on understanding the principles of community-based research, patient involvement in research, and there was less work that was published on, so how do you actually do it? How do you involve and engage patients in trials research? And so they formed a team of researchers who had worked with patients on, they use the term service users, but service users as an umbrella term to refer to patients, carers, and other people impacted by the clinical trial work. So they formed a team of researchers with experience working with patients or service users, as well as patients and service users themselves, to come up with what they call a standard operating procedure for involving patients in clinical trials. And so they identify various committees and groups where they recommend patients can be involved in the trial. So I'll just kind of walk through these. So first is the trial steering committee. You'll see that I have green and will, and should is in orange. So what I understand them to be saying is that where there's a will, that's kind of the difference between a must and a may. So they really recommend that at least 2 patients be involved in a trial steering committee. So this is a must. And this group would contribute to decision-making about the design, conduct, and reporting. So kind of the governance of the trial. Data monitoring and ethics committee, and this group would contribute to decision-making about safety, benefit, and recruitment. And here they recommend that 2 patient partners or service users may be involved in this committee. The trial development group would contribute to decision-making about all aspects of the proposed trial. So this is at the stage of proposing the trial and writing it up. The trial management group contribute to decision-making about all aspects of the funded trial. So once the trial gets funded, and so for both of these groups, patients, patient partners or service users should be or must be included in these groups. And then the trial research team, this is the team that does the work of across the trial. And then the ad hoc operational meetings. So here they would collaborate in task-oriented teamwork across the trial. So for these 2 groups, patient partners and service users are recommended to be on this on these teams. So I want to just highlight a couple things here. I think it's important to recognize that they recommend patients, partners or service users be involved in the decision-making committees. I think that's really important to keep in mind. They also recommend that at least 2 patient partners or service users be involved in these committees. And I think this is really important to keep in mind. They recommend 2, and then they recommend training a 3rd person at minimum so that they can participate on these committees in the case that one of the patient partners or service users isn't able to participate. This is so that there are at least 2 on these committees. And this, if we think about the power relations between patients, community members, service users, and then a team of researchers or clinicians, it's important to ensure that patient partners, community members feel that they're able to speak up in these meetings, on these committees, and to ensure that the power relations between the researchers, clinicians, patients and community partners is more equitable. The other thing that they highlight is that it's really important to provide sufficient training. And this is really, really important to avoid tokenistic participation by community partners. It's to have patient partners, service users, community partners to engage in a meaningful way. They need sufficient training in some cases to be able to do so in a way that they feel informed and that they feel they're able to contribute in a meaningful way. And they emphasize you can't underestimate how much time and resources that will take. And I have certainly experienced that in my research projects as well. When community members are involved, if they want to be part of the data collection, for example, or various aspects of data analysis, it's really necessary to ensure that they have the sufficient training needed to be able to carry that out, and that they have the resources to be able to do that in a meaningful, effective way. The final thing that I'll just say about this, the SOP and the recommendations that this team makes is they recommend setting aside money in the budget for this work. So for the work of training patient partners, for ensuring that they have the resources necessary to do their work, any travel costs that they might have to be able to attend meetings, and they recommend at least a minimum of 1% of the research budget goes towards this. So this project here, in terms of the challenges and tensions of conducting patient-engaged research in clinical trials, I ran across this study, and I think it was a really interesting one. They, this is the first study, they write the first study, I think it might be the only study, where they examined whether plans for patient and public involvement as documented in clinical trials applications, and they looked at the period between 2006 and 2009, and were actually implemented. So they found 28 trials applications in this time period. And of those 28 trials, 25 applications said that they would include patient and public involvement. What they did, an additional part of this study, is then they conducted semi-structured interviews with the PIs and patients to identify challenges to implementing patient involved or patient engaged research, and some of the lessons learned and recommendations from these semi-structured interviews. So from the interviews, they found that 20 of the 25 studies fully implemented the PPI plan, with some of them having actually expanded the involvement of patients and publics beyond what they had written up in their project, in their application. On the other hand, some PIs said that in the interview that the involvement of patients in their project remained largely tokenistic, and they didn't feel that the patient partners were involved in a meaningful way. And so this table here that I have outlines some of the challenges that were identified by the clinical investigators and the patient partners. And some of them are challenges that kind of involve both groups. The top half of the challenges and the bottom half are challenges that are unique to or specific to one group or the other. And so just to kind of highlight a few, so both groups recognize that uncertainty about the rules in relation to the patient partner was a challenge, and noted that the patient contributors lacked confidence and difficulties in attending some of the meetings. So this gets at the importance of ensuring that patients and patient partners, community partners, have the information they need, that the committees and meetings are run in a way where they feel that they can contribute in a meaningful way, as well as the need to be very clear about what it is you're asking community partners and patient partners to do on the project. Patient, public, PPI contributors also experience problems in interacting with researchers and understanding technical language. You can see that they highlight jargon as a concern. Researchers reported difficulties finding the right, in quotes, PPI contributor. I think it's also interesting to note that some of them found that some of the PPI, the contributors they use the language of poached by other teams and other trialists. And then they advised caution when involving investigators, current patients. So I think this is a really important one to consider for folks who are clinicians and conducting trials. Just what is the relationship between you as a clinician and the patient partners who are participating in this study and engaging with you on it. So then the authors come up with some tips for clinical trials. Start early. Begin planning. So they say begin planning and consulting with contributors as early as possible. I have found in my own work that this can't be emphasized enough. It's really important to start early and to start talking with community partners as soon as you start having some ideas about a project, and or you're interested in pursuing an idea or studying something involving community partners as early as possible, patient partners as early as possible, will allow you to integrate their perspectives, their needs, their concerns as soon as possible. It's also really important to start early, to start building the relationship that you need to build with patient partners and community partners. Be flexible. Here, they also recommend involve more than one or two patient partners or patient contributors, and also more than once or twice a year. So as the PPI contributor noted in that table on the previous screen, they felt that they didn't meet frequently enough. So if the patient, the committee that the patient partner is on meets only, twice a year, that might not be enough to engage with them in a meaningful way. It might not be enough for them to feel that they have built up enough of a relationship to contribute meaningfully and to feel comfortable to contribute. It's also the case that a lot of times research, the project might change as it continues, and so it's important to be flexible and to gain insight from the community partners or patient partners as you do so. And they recommend communicate, clarify, and interact. So again, this is about being really clear about from the outset what the roles and expectations of patient contributors as well as the researchers are from the very beginning and then throughout the trial. And this will really help to optimize optimize engagement of the patient partners throughout the work. Use accessible language. Again, they recommend avoiding jargon as much as possible. Also avoid acronyms. A lot of times, when you're kind of in group, you use a lot of acronyms that everyone kind of within your kind of group is familiar with. But as soon as you have people outside of that group participate, the language and acronyms aren't understandable. I would say in my experience, there's no quicker way to kind of like signal in-group, out-group as, the use of acronyms and jargon that are specific to one group of people. So again, to the extent possible, ensure that the language you use is accessible. Budget for PPI, and this is consistent with the recommendations or the standard operating procedures outlined by Evans and colleagues. So make sure that there's money in the budget to support patient engagement, and then fit for purpose patient public involvement. So this is about thinking through plans for PPI and center them around the aims and needs of the trial. They recommend that there should be agreement about an understanding of what and why PPI is needed, and why and what will help in planning it. So I want to, there's a last slide here. I'm not going to do justice to evaluating CBPR. I think this is really important in an area that I'm learning more about right now. But it's important for us to evaluate how well we're applying this approach to research. And the public, there is a public and patient engagement evaluation tool that was developed by Julia Abelson and colleagues out of McMaster. Julia Abelson has written extensively on the topic of patient and public engagement in health research, and I would recommend reading her work on this topic. There's also the Center for Excellence on Partnership with Patients and the Public, and they have various evaluation toolkits on offer on their website as well. And then lastly, I wanted to just provide some resources here. So again, the Canadian Centre for Excellence in Patient and Public Engagement, CIHR SPORE network. There are 11 SPORE support units across Canada. So there's the link there. the Ontario Spore Support Unit. They just celebrated their 10-year, I believe it's 10-year anniversary. And they have a lot of really good resources as well, if you want to check them out. And then the one of 14 OSU research centers, so the Ottawa Spore Support Unit Research Centers, is a Clinical Trials Ontario. And with that, thank you, and I'm happy to take any questions.
Thanks so much, Jenny. That was great and very, very useful and relevant to our group. We may have time for one or maybe two questions. Anyone in the audience have any questions for Dr. Haw? All right, well, you're mulling it over. I have a question. So I think, specific to the kind of clinical trials that the transfusion medicine community engages in, sometimes the patient subjects are pretty clearly part of a community. Like I think sickle cell disease is a good example. You could even argue that patients with hypogammaglobulinemia secondary to a malignant hematologic diagnosis think of themselves as being part of a community too. And I think it's relevant for a study that we're going to be engaging with, trying to convince these patients to go on antibiotics instead of IVIG. And I think you've made a good point that, engaging that community will mean, among other things, that the clinical trial is more likely to be successful. But in other situations, it's really hard to think of the patients that we're enrolling as being part of any kind of defined community. Like sometimes these are patients, the only thing they have in common is that they're in an ICU and unconscious while they're in there, or are under anesthesia, undergoing cardiac surgery. And I feel like it might be kind of forcing it to sort of ask anyone to represent those patients as a community representative. And I'm wondering, would you ever apply these same principles of community partnership to the caregivers who are taking care of these patients? Because that's often who we're actually trying to intervene upon. It's the ICU doctors, it's the cardiovascular surgeons. Like, do these same principles apply?
That's a great question. And I think that, just in my reading and understanding and my experience, so, who or what is the community is a really important question to tackle. And I think that that's kind of what you're getting at. Like, who do we mean when we refer to the community? Who do we mean when we refer to the patient?
Mhm.
And in some of the examples that you gave where people are unconscious, it's they're less able to be involved actively, at least at the time. And certainly in the literature with patient-engaged research or patient-oriented research, that term patient is a very broad umbrella term. So we can refer to patients or caregivers. So maybe not the patient themselves, but other informal caregivers. So family members, friends, loved ones who are closely involved in the care of that patient, or other people who are involved in the care of that patient, who might have an interest in and concerns for the best outcomes for the patients involved. I think community can be it's important to think about what we mean by the community, what we mean by the patient, and who might we want to invite into this discussion to provide their input and expertise and lived experience to the work that's being done, and who really has kind of a stake involved, and who would be impacted by what might happen. And I think absolutely you can think beyond that specific patient lying on the table, to broaden that network out. And it might start with a conversation with caregivers of patients who are undergoing, who are, as you said, unconscious, and but caregivers, and ask them who else should we bring to the table? Who else has an important perspective to share here, who might have a stake in what it is that we're trying to do?
Okay, but you wouldn't say like other physicians would ever kind of meet the definition for what you're advocating for. Like they're too much on the sort of on our side of the power differential.
I mean, I think, you can invite other clinicians, perhaps onto like, they, maybe onto the research team. You might want to gain their perspective on what it is that they do. Um, I think that's it's an important question you ask, right? Because I think if we think about the roots of community-based research, even patient-engaged research, it really was about um, bringing into uh, uh, understanding that power differential between
Hmm.
those of us who do research and and people who were trying to understand and study, and really kind of upending that power differential, so to speak.
Okay,
So
understood.
I guess I would say it really depends on the context of the study, the research question you're trying to understand, and how the different, perhaps clinicians, service providers, how they might, uh, what role they might play in that network, and what it is that you're trying to understand.
All right. I think we're probably out of time. I'll just, somebody left an important comment in the chat about plasmapheresis or plasma exchange therapy trials involving family, friends, other parts of the care circle. So it's not just the patients themselves necessarily. Okay, well, we're just a little bit over time, so we will adjourn. Thank you so much, Jenny, for a always illuminating talk. And everyone, we will have our next session currently booked for May 15th, and we will be talking about funding and how to get money for your trial with Dr. Karkouti. Okay, thanks everyone.
Thank you.